Atrial fibrillation. Is it complicated? Is it hard? Is it confusing? Don't worry. Let me break it down into simple parts so that you can demystify the roadmap. It's all based on this. Stay tuned. I'm Dr. Ishfaq and you are watching the Medicable Forum. Atrial fibrillation. It is actually a disorganized electrical activity of the atria. So basically your atrias are contracting like this. They have no coordinated activity. Due to that it can lead to so much of circumstances. So we'll break it down into these simple steps. You have C, C, A, B, C now. That is the mantra we are going to use throughout this series. So C, C, A, B, C. So let's just quickly break it down. What is C? First, you got to confirm. You got to confirm that it is an AF. Then, after confirming, you got to characterize. You got to characterize the AF. How do you characterize the AF? So now you have something called the 4S. The 4S strategy. So you confirm, characterize using the 4S strategy, which I'll be telling you soon. Then, this is how you treat. That is how you treat ABC. Anticoagulation, better symptom control and controlling the comorbidities. Anticoagulation, better symptom control, control your comorbidities. Simple as that. And I'm sure after this video, atrial fibrillation will be at your fingertips. First of all, let me talk to you about atrial fibrillation in general. So, if you look at the demographics, like here, if you look at the demographics, you would see that the red zones are in the Scandinavian and the American Canadian population because it is mostly attributed to alcohol. But apart from the Asian subcontinent zone where you don't see it much, right? The most common cause of atrial fibrillation there is most of the time hypertension, right? And then also, if you see the complications of atrial fibrillations, what sort of things it can lead to, death is quite common. It can lead to heart failures. And did you know that 20 to 30% of strokes, 20 to 30% of strokes are due to atrial fibrillation alone. That is why anticoagulation is one of the most important parts of the management. So if you look at the etiologies of atrial fibrillation, you know there are so many factors. There are factors which can be associated with your comorbidities like hypertension, like previous ischemic heart disease, cardiomyopathies. It could also be endocrine like hyperthyroidism, thyrotoxicosis. It could also be other metabolic causes. It could also be some concurrent illnesses which you are having. You could be in sepsis, you could be in lower respiratory tract infection. Even those can predispose to atrial fibrillation. And then there are a whole lot of other causes which depends on your metabolic status like your obesity, metabolic syndrome, etc. So these are your etiologies and this is the brief overview what you have to have in your head about atrial fibrillation just before you get in to manage it. So simple as that. CC, ABC. Now let's look at how to confirm AF, right? So there are two things what you have to know. People can present as AF not alone. They come with various types of symptoms. They can even come asymptomatic and you will incidentally find AF, or else you can find it in a symptomatic manner. So in patients who are symptomatic, they can be either hemodynamically unstable or hemodynamically stable, right? So what do you mean by hemodynamically unstable? Chest pain, shortness of breath, hypotension and confusion. Chest pain, shortness of breath, hypotension and confusion, right? This means that they are hemodynamically unstable, right? So When a patient comes to you with those sort of symptoms, or even if he comes to some other reasons, and in your examination you notice that there is a irregularity of the pulse. There is a irregular pulse. Irregular pulse. So there is a irregular pulse. Now this is the point where you have to take a ECG. So actually there are two steps. Okay. Number one is the ECG. That ECG should be a 12-lead ECG. The strip should be at least 30 seconds and it should show irregular RR intervals and non-sinus rhythm. So 12-lead ECG at least for 30 seconds, irregular RR intervals and non-sinus rhythm, which is no discernible P waves. So this is how you diagnose AF, and now this one you call it clinical AF. Now this is a clinical AF. So clinical atrial fibrillations should be treated. Now there is something which I want to tell you. Subclinical AF. Now what is subclinical AF? Now you have monitors which continuously monitor heart rate. It could be your smartwatch, it could be your smartphone, it could be any object which you are wearing which continuously monitors your heart rates. So they can detect atrial high rate activity. It's called AHRA. Okay, they can detect atrial high rate activity. Now if they detect atrial high rate activity and then you take an ECG and there is no AF in ECG, now that is called a subclinical AF and you don't have to treat it. Now that is called atrial high rate activity. So these are the two terms which you have to be thorough with. Atrial high rate activity, which is a subclinical AF, and the clinical AF where your ECG shows diagnostic features. Now once you diagnose, the next step is characterize. Now you've confirmed your AF, now your patient has atrial fibrillations. Now let's go and characterize. So characterizing AF has four main principles. It is named 4S. It's very easy. So the first S is stroke risk. The first S is stroke risk. So here you have to use the Chadwick score. You have to use the Chadwick score to see if there is a risk of this patient developing a stroke. What's the next? It is the severity of symptoms. This is the severity of symptoms. That means you are trying to find out, based on the patient's symptoms, how severe is this episode. So just look at this. Now this one is the EHRA scale, where it is a questionnaire where it depicts you on a scale of numbers how severe is the symptoms. So you have scales. So depending on those scales, you can find out how severe the symptoms are. What's the next S? It's the substrate burden. It is the substrate burden. Now what is the substrate burden? That means they should have some substrate, like left atrial dilatation, there can be some fibrosis, right? There can be some scarring of myocardium. So these sort of things can predispose to atrial fibrillation, so we need to look at them as well. So that is what we call the substrate burden. So stroke risk, severity of symptoms, substrate burden. Now the next one is, it is the severity of AF burden. So it is the severity of AF burden. That means if this patient is having an atrial fibrillation, for how long is he on atrial fibrillation? It could be a short paroxysm, it could be his new onset of AF, it could be a paroxysm. It could last more than 48 hours, it could last until 1 week, which we call persistent. It could last until even 1 year, it is long-standing persistent. It could be even chronic. So these are the types of AF burden. So as long as they are on AF, if they don't have better symptom control, they can have issues. So that is why you have to characterize. So once again, to recap, 4S to characterize after you confirm: stroke risk, severity of symptoms, substrate burden, severity of AF burden, and it's simple as that. Now once you've done this, the next is jump into treatment, which is A, B, C. Next, we'll talk about how to manage an atrial fibrillation. So first we learned about how to confirm, how to characterize, and now let's go to manage. So when I was talking about how atrial fibrillation manifests, they can manifest symptomatic or asymptomatic. No? So when we talk about the symptomatic ones, we have to mainly have two different distinctions. One thing is hemodynamically stable. Hemodynamically stable. So this is one entity which we are going to focus on. The next one is hemodynamically unstable. Hemodynamically unstable. So what do you mean hemodynamically unstable? So what does that mean? So if the patient is coming with chest pain, shortness of breath, hypotension and confusion. Chest pain, shortness of breath, hypotension and confusion, they are called hemodynamically unstable. So atrial fibrillation can come as hemodynamically stable or hemodynamically unstable. So this entity is easier, right? So if the patient comes hemodynamically unstable, regardless of the duration, whether it is a new one or a chronic one, it doesn't matter, we have to cardiovert. We need to cardiovert, right? Usually we use DC cardioversion after procedural sedation. DC cardioversion after procedural sedation. But there's one downside for this. Now, if they have been having this atrial fibrillation for quite some time, definitely they will have some thrombus in the left atrium. So definitely after cardioversion you are having a risk of the patient going into some stroke, but at this point he is hemodynamically unstable, he might die due to this episode, so that is why you need to cardiovert. But look at this entity. If you are talking about hemodynamically stable people, okay, you have to divide this into two. Whether it is less than 48 hours or more than 48 hours. Whether it is less than 48 hours or more than 48 hours. Now, in a patient who is coming more than 48 hours, it is said by evidence that if there is an atrial fibrillation going on for like around more than 48 hours, you definitely have a risk of having thrombi in your left atrium. So, cardioverting or reverting the rhythm into sinus rhythm in this position will pose you for a risk of developing a major thromboembolic stroke, right? So that is why these patients, if they are hemodynamically stable, so first is rate control. First is rate control. You control the rate. I will talk to you how we control the rate, but this is the analog what we have to have it in our head. This is the theory. First you control the rate. Then you give anticoagulation. You give anticoagulation for how long? For 28 days. You give anticoagulation for a month. And after that, you do a transesophageal echo. After 1 month, you do a transesophageal echo. You exclude the possibility of left atrial thrombus, and if there is no thrombus, then you go for DC cardioversion. Then you go for rhythm conversion. But look at this. This entity, hemodynamically stable. So if they are hemodynamically stable and less than 48 hours, you don't have a risk. So what you do is you can directly go for DC cardioversion, revert the rhythm, but mind you, after cardioverting, after getting the rhythm back, for 1 month, you need to put them on oral anticoagulants, and later you can re-evaluate and stop. So this is the whole plan of how to manage an atrial fibrillation depending on whether they are hemodynamically stable or unstable. Stable and unstable. It's quite simple. Now let's get into the real deal, the long-term plan. Now let's step into the long-term management. So we know the long-term management is quite simple. Just follow A, B, C. A, B, C. Anticoagulation, better symptom control, and controlling your comorbidities. So now what about anticoagulation? So what about A? The thing is, if a patient has an atrial fibrillation due to a valvular problem, which is mostly predominantly involving the mitral valve, it could be a mitral valve regurgitation of a grade 3 or more, or it could be a mitral stenosis. Other valvular disorders are not considered as significant to label it as a valvular AF, because it has to pose some volume or pressure overload on the left atrium, right? So that is why the mitral valve is per se considered. So if it is a valvular AF, there is no question. You don't have to look at any Chadwick score. You need to anticoagulate them. But if this AF is not due to valvular causes, if it is a non-valvular AF, then you have to risk stratify, and according to that you need to anticoagulate, right? So we have this Chadwick score, CHA2, DS2, VASC, right? Now let me break this down to you. If you have congestive heart failure features, you get 1 point. If you have hypertension, you get 1 point. If the age is more than 75 years old, you get 2 points. Remember, here you have 2 points. Then, if you have diabetes, you get 1 point. If you have strokes, due to this, you get 2 points again. Then, if you have some vascular phenomena, what do you mean by vascular phenomena? Like coronary artery disease, peripheral vascular disease, then you get 1 point. Then there is another age category if the age is between 65 to 74. So here you get 1 point. So here remember the age, if it had been more than 75, you have got 2 marks. But here age between 65 to 74, it's just 1 point. And then finally, if you are a female, you automatically qualify for 1 point. So congestive heart failure, hypertension, age more than 75, diabetes, stroke, vascular phenomenon, age and female. So this is your Chadwick score. Now according to this Chadwick score, if you are a male, if your score is more than 2, you need oral anticoagulation. You need oral anticoagulation. If you are a female, if your score is more than 3, you need oral anticoagulation. For a female, the score should be more than 3. For a male, the score should be more than 2. Now, if the score is more than 1 but less than 2, then you have to consider antiplatelets. Now here, if the score is more than 1 but less than 3, you need to consider antiplatelets, right? Now, considering antiplatelets is not the important focus what you need to have. The distinction is when to start anticoagulation or not, because 20 to 30% of all strokes are due to atrial fibrillation. So that is why if a patient comes with atrial fibrillation, we need to stratify them according to this score and find out do they need anticoagulation or not. So this is how you manage the anticoagulation. But this is not it, because the anticoagulation drugs per se can cause side effects. There is a bleeding tendency. Now, we have to stratify the patients. When we are starting them on anticoagulation, we need to talk to them about the bleeding risk. So, we need to stratify how prone are they to bleed. So, we have another risk score which is called the Has-Bled score. So, now we spoke about Chadwick's score. Now it's time to speak about Has-Bled. Now, Has-Bled is a score devised to characterize your patients according to the risk of bleeding when you start anticoagulants, right? So, having a higher Has-Bled score tells you that the patient will have a high risk in bleeding, but it does not tell you that oral anticoagulants are contraindicated, right? Nice to understand. It does not tell you that the oral anticoagulants are contraindicated. It just tells you that you will have to monitor them quite frequently, right? So, what is this Has-Bled score? Let me break it down to you. So, H is uncontrolled hypertension. Uncontrolled hypertension, if the blood pressures are persistently more than 170 millimeter mercury systolic, now that is a risk of bleeding. Next, you have altered LFT or RFT. So you have altered liver or renal functions. Now they are also a risk of having bleeding. So each derangement will get you 1 point. Alright. Next, previous strokes. Now previous strokes, it could be ischemic or it could be hemorrhagic. It could be ischemic or it could be hemorrhagic. Now, having a history of such strokes is a predisposition to have a bleeding event. Next is the bleeding tendencies. Bleeding tendency. Now, what do you mean by the bleeding tendency? Has the patient had any major bleeding episodes, major blood loss, major GI bleed where he has had some GI ulcers or something like that? So, if there was a history like that, so that is also a risk for having large bleeding episodes. Next is called the labile INR. The labile INR. Now, what is labile INR? Now, when we are prescribing vitamin K antagonists for patients, we monitor the therapeutic range with INR, International Normalization Ratio, right? So, if the INR is fluctuating, it is not remaining in their therapeutic targets. Now, that is a labile INR and that is a risk for bleeding. So, there is something called time in therapeutic range. Now, if the time in therapeutic range is less than 60%, so that tells you that the patient's INR is labile. So the time in therapeutic range. So that is about labile INR. Next, elderly people. Elderly, more than 75 years old. So elderly patients more than 75 years old. Now, elderly patients more than 75 years old has a high risk of bleeding. Next, finally, we go into the drugs. Now, what do I mean by drugs? Now, alcohol consumption. If the patients are on alcohol, they are having a high risk of bleeding. And also, if the patients are on antiplatelets or antithrombotics, now together with the anticoagulations, now that can also pose a risk. So each point has gets 1 point for each and every derangement. So if the has bled score, if the score is 0 to 2, we consider it as a low risk of bleeding. If it is more than 2, it is considered a high risk. If it is more than 2, it is considered a high risk. So if you have more than 2 in the Hasbled score, it does not mean that you have to withhold your anticoagulation. It just means that you have to follow them up more regularly, be more watchful. Now that is how you manage your anticoagulation and adjust the bleeding risk. And according to this, you need to address the patients on how to make them choose. Now you have 2 options. You have vitamin K antagonists like warfarin. You have oral anticoagulants. There are multiple agents: rivaroxaban, apixaban, dabigatran, right? The direct oral anticoagulant. So always remember, if the atrial fibrillation is due to a valvular cause, the evidence says that the recommended choice is the vitamin K antagonist. It is warfarin. If the atrial fibrillation is non-valvular, then the recommended one is your direct oral anticoagulants. So remember that. So you can't forget that and you can't alter that. Now depending on that, you have to talk about their pros and cons, and that I'll discuss it on another section. For now, let's stick to the long-term management plan. So we are done with A. So next we are going to better symptom control. Next we are going to talk about B, better symptom control. Now what do you mean by better symptom control is that now when a patient comes to you with atrial fibrillation, they would have certain limitations of their day-to-day activities, right? So they should be able to carry out their normal activities of daily living. So there are these questionnaires where you can use to assess the severity of their symptom burden, which we assess when we are characterizing. So according to that, we need to make sure that we give them drugs, we give them some treatment to make their life good. So that is what we call better symptom control. So here, with better symptom control, we are trying to control the heart rate. Now, there are some instances when a patient comes to you with atrial fibrillation, it warrants you that you have to change his rhythm. Now, like I've said earlier, there are various definitions of atrial fibrillations. It could be your first episode, it could be a paroxysm, it could be persistent, it could be a long-standing persistent, or it could be a chronic. Now, a patient who is chronically in AF, there is no point in reverting him into sinus rhythm because he will go back into atrial fibrillation. Now, patient's rhythm being changing like that is a major risk factor for stroke risk. So, we don't do that. So, if the patient is comfortable in AF, we keep them in AF with a controlled heart rate. That is what we have to do. So, here are some risk factors which will tell you that reverting them into sinus rhythm is much better. So, young age, first episode of AF, not having any comorbidities, no structural heart disease. If the atrial fibrillation is stimulated by a certain current illness like a respiratory tract infection or even a simple sepsis. So, they tell you that cardioverting them will make them sure that they will be staying in sinus rhythm for longer than others. So, you need to understand that concept. So, whenever your patient is coming and you are trying to prescribe better symptom control, you need to evaluate that if the patient should be in sinus rhythm or in AF. Now, if he is in AF, now next step is how to control the heart rate. Now, we have a concept called the lenient heart rate. We have a concept called the lenient heart rate, which is less than 110 beats per minute. Now, how do we know that this is the lenient heart rate? Now, depending on the patient's day-to-day activities, we have to continuously monitor their heart rates by either smartphones or smartwatches or by attached cardiac monitors. So we monitor their heart rates according to their day-to-day activities and see that what sort of heart rate makes them more comfortable. So by evidence they have come to a conclusion that keeping a heart rate less than 110 is a lenient heart rate. So what are the options we have? We have beta blockers. Then we have calcium channel blockers. What else? We have digoxins. Then last, we have a anti-arrhythmic drug. What is the drug we are going to talk about here? We are going to talk about amiodarone. Yes, you heard it right, amiodarone. So when you talk about these drugs, so what are the options available? So beta blockers, you have bisoprolol, you have atenolol, you have metoprolol. So if you talk about calcium channel blockers, they are the non-dihydropyridine calcium channel blockers, like you have verapamil, you have diltiazem. You have verapamil and diltiazem. Then you have the digoxins, and then if all fails, then you go for amiodarone, right? So the choice of drug also depends on the comorbidities the patient has. Now let's say the patient does not have any comorbidities, structurally normal heart, but he has a atrial fibrillation. So you can go for beta blockers as the first option. Then you can go for calcium channel blockers, right? So let's say the patient is asthmatic. So now you can't use COPD or asthmatic, you can't use beta blockers. Then you go for calcium channel blockers, right? Simple as that. So if the patient has heart failure, first you need to go for beta blockers, then you need to go for digoxins, because digoxins are positive inotropic agents, so they will load the calcium into your heart muscles to increase contractility. So digoxins will control heart rate better in atrial fibrillation with heart failure. So the better symptom control helps you to not make them go into heart failure, because the more the heart works, the less the heart gets blood from the diastole, as you remember. So make sure that the patient is at the lenient heart rate. So these are the options we have. Now in a patient who has heart failure with atrial fibrillation with all maximum drugs but still not getting control, then what are you going to do? Now you assess the left ventricle and right ventricle function. Now are there a dyssynchrony going on? Are there some bundle branch blocks developing? If they do, now that is the time where you insert devices. That is where you go for devices. You go for cardiac resynchronization therapy, where you resynchronize both left and right ventricles. So here you are aiming for a much lower heart rate than 110. You are aiming for a heart rate of 80. You are aiming for a heart rate of 80 with a CRT device. That is when all of these drugs are going on and still the patient has no response, right? So that is where when you use devices. After this, there are so many surgical methods which can be used, like ablative methods. So they also can be tried when these fails, and you don't have to know them in detail. If you want, you can always read the European Society of Cardiology guidelines for atrial fibrillation to know more on them. Right. So that is regarding better symptom control. So now let's move on to C, which is about comorbidities. What I mean by comorbidities is cardiovascular risk factors and related comorbidities. Next, we are going to talk about C, which are the comorbidities. In that, what I mean is cardiovascular risk factors and comorbidities associated with that, which make the patient more prone to have atrial fibrillation. So it's important that we target them and control them as well. So look at this. You have obesity, hypertension, poor glycemic control, alcohol consumption. Now obesity related complications like obstructive sleep apneas, those sort of things we need to make sure that we look at them and we have to control them. So by controlling them, we reduce the risk that the patient is going to have further episodes of atrial fibrillations. If at all, we revert them back into sinus rhythm. So that is a small part of C, where I wouldn't need to explain this in detail. So this we can be discussing further sections in our videos. But in general, while managing an atrial fibrillation, it is easy. C, ABC. Confirm, characterize. You characterize by the 4S strategy. Then you go for the long-term management. Anticoagulation, better symptom control, and control the cardiovascular risk factors and the comorbidities. And that is how you manage an atrial fibrillation. If you do have any questions, please comment down and let me know so I can reply you then and there. So I hope you learnt about the basics of atrial fibrillation. So I am sure after looking at this video you would realize that how easy is atrial fibrillation. It's not confusing as you thought. Now everything is in your fingertips. So if you love this content, please do subscribe, leave a comment and click on the bell icon, and please do share and subscribe.